Welcome to The Explainer. Today, we're diving into the key management principles for pediatric atopic dermatitis, pulling from a fantastic recent review in Pediatrics in Review. We're going to focus on a really practical, algorithmic approach that you can actually use in a busy clinic.
Okay, let's just get this on the table right away. The absolute core principle here is being pragmatic. We are managing a chronic condition. There is no cure. So our goal, and the family's goal, has to be about disease control. This mindset shift is everything for setting realistic expectations from day one.
All right, here's our game plan. We're going to build this just like a clinical algorithm, moving from the absolute basics to our first-line therapies, then what to do when those don't work, and finally when to escalate.
First things first, let's lay the foundation. These are the non-negotiables, the things that have to happen for every single patient with AG, no matter how mild or severe.
So before you even think about that prescription pad, there are two critical elements: education and what the article calls aggressive moisturization. And the data here is just so compelling. Look at that. Consistent twice-daily moisturizing can buy a patient almost 2 extra weeks without a flare. And remember, the best moisturizer is the one they'll actually use. It doesn't matter how fancy the brand is if it stays in the jar.
Okay, foundation is set. Now let's get into our workhorse, our #1 tool for fighting inflammation, topical corticosteroids, or TCS.
And here it is. This is the central conflict, the paradox we all face in the clinic. On one hand, we have 70 years of rock-solid evidence from over 100 randomized controlled trials. These things work. But on the other hand, we have this widespread fear, this TCS phobia, that completely torpedoes adherence and is a huge reason for treatment failure.
So here's a quick and dirty reference for picking your potency. You know the drill. Low potency for the sensitive spots like the face and skin folds. Then we ramp it up to mid or even high potency for the trunk, the limbs, or those really stubborn flares.
This brings us to the million-dollar question, doesn't it? This is the question that's in the back of every parent's mind, and we have to be ready to answer it head-on. What is the actual evidence-based risk?
Let's be really clear about this. The evidence is overwhelming. Skin thinning or atrophy is incredibly rare when these medications are used correctly. Most of the scary reports you hear about involve things like slapping ultra-potent steroids on the face under occlusion, things we'd never recommend. In fact, that key 2011 study showed that even long-term, appropriate use of moderate to high-potency steroids didn't cause skin atrophy in kids. The #1 fear just isn't backed up by the data.
And if you wanted to know the scale of the problem, just look at that number, up to 95.7%. And that's not just patients and caregivers, that includes other healthcare workers. This phobia is a massive barrier to getting these kids better.
So we have to fight this head-on. And here is a proven 3-step playbook for every visit. 1, you have to educate and reassure. Talk about the real risks versus the huge benefits. 2, you have to show them, demonstrate the fingertip unit, show them exactly where to put it. This makes a huge difference. And 3, give them a simple written plan. Treat until clear. This simple process works.
Okay, so what if TCS just aren't the right choice? Maybe because of that caregiver fear, or maybe we're looking for maintenance therapy on a sensitive spot. Let's look at what's in our non-steroidal toolbox.
First up, we have the old guard of non-steroidals, the topical calcineurin inhibitors, or TCIs. You know them, tacrolimus and pimecrolimus. They work by tamping down T-cell activation and cutting the production of those inflammatory signals.
The huge advantage here is that TCIs don't cause skin thinning, which makes them absolutely ideal for sensitive areas like the face, eyelids, and groin. Now, you have to talk about the elephant in the room, that black box warning. It's crucial to explain that while the warning is there, extensive, long-term safety studies have not found a real increased risk of malignancy with their use. All right, next up are the topical PDE4 inhibitors. This group includes crisaborole and the newer roflumilast. They take a different path to get there, but the goal is the same: reduce inflammation by inhibiting that PDE4 enzyme.
The big selling point for these is their really favorable safety profile. And we've got fantastic options across the age range. Crisaborole is approved all the way down to 3 months old, which is incredible. And then roflumilast is a new, really potent, once-a-day option for kids 6 and up, which is great for adherence. And now for the newest kids on the block, the topical JAK inhibitors, like ruxolitinib cream. You want to think about these for those cases of mild to moderate AD where your other topicals just aren't getting the job done.
Ruxolitinib is for our non-immunocompromised adolescents 12 and up, and it's a real powerhouse, not just for the eczema itself, but especially for the itch. Now, yes, there is another black box warning to discuss, but it's really important to explain that this warning is based on the oral JAK inhibitors. With the topical cream, studies show that very little gets into the bloodstream, so significant systemic side effects are really unlikely.
Okay. We've all been there. The family comes back for follow-up looking defeated and says, "Doc, it's just not working." It's a classic scenario. So what do we do next?
Before we even think about changing the script, we have to play detective. And the first question is always this one. Is it the medicine that's failing, or is it how they're using the medicine? Because the data shows that poor adherence, usually driven by those fears we talked about, is the most common reason for what looks like treatment failure.
And here's our troubleshooting checklist, adapted right from the paper. Are they just putting on a tiny dab? Are they mixing it with moisturizer and diluting it? A huge one is stopping treatment the second it looks a little better, not when it's totally clear. Just going through this list with the family can often solve the problem right then and there. Okay, so you've done your due diligence and you're sure they're using it perfectly. Now we can start thinking about true therapeutic failure. This becomes our new differential. Could it be the wrong diagnosis? Is there a sneaky secondary infection? Do we just need to level up to a stronger steroid or switch from a cream to an ointment? Or maybe it's time to start proactive therapy on the weekends, or even call for a dermatology consult.
And finally, for those kids with tough, moderate to severe disease who just aren't getting control despite our best efforts with topicals, we can't let them just suffer. It's time to refer for the big guns. And the options now are incredible, ranging from phototherapy and traditional agents to the highly targeted biologics and oral JAK inhibitor.
So in the end, it really all boils down to this, doesn't it? We have the right therapies. We know what to prescribe. But are we spending enough of our precious clinic time on the how? Because successful AD management isn't just about writing the script. It's about being a teacher and a coach. It's about building the trust that empowers families to turn our clinical knowledge into their daily disease control.